actually, sort of structured this discussion in a way, I mean, I actually call it a question of answers. All these are the questions that my residents ask me. And that's why I have sort of subdivided this entire talk into 5 topics, which is understanding the basic hemodynamics. I think that is very important to understanding the echocardiography in constrictive pericarditis and restrictive cardiomyopathy. Then understanding exaggerated interdependence, that's the extremely important word because interdependence of ventricles is normal even in a normal respiration. Exaggerated interdependence is what actually leads to these hemodynamic changes, echo Doppler and tissue Doppler of both, cath correlations, how we look at it in the cath lab and how we take our cath lab to the echo and echo to the cath lab, and some real life conundrums. So as I said, this is, it's a scary topic to actually talk about pericardium. JVP is known as the graveyard of cardiology exams. I'm sure Dr. Bhagirath, if he was here, would have agreed to this. And then most, it's read mostly the night before, and most commonly Kussmaul somewhere, some pulses paradoxes, some this, some that, some broadbents till the exam happens, and then again we come out till the next exam. You've again forgotten this. So in any case, essentially CP versus RCM is a disease of shell versus a disease of the muscle. This is how Dr. Kothari used to teach us his aims. Always, it's a disease of the shell versus a disease of the muscle. So that's actually what brings in the change in the hemodynamics in each disease. The basic pathological differences is a thick skin, as I said, and a stiff muscle. So if you have a stiff muscle versus a thick skin, exactly what is causing the hemodynamics? Because one, that is the first one, is imminent death, and the second one is essentially life. So if we look at, if I were to talk about this, this is a kind of a busy slide, but then we always differentiate it more on the hemodynamics and more on the clinical aspects other than on the thickness of pericardium. There's nothing really sacrosanct as a number. Dr. Bhagirath, I just mentioned you, sir. Dr. Prayag here. Yeah, afternoon to you. So has been my teacher. It's wonderful coming back to NH because I started my journey in Bangalore in NH. So in any case, it's actually a clinical and a hemodynamic profile that is much more important than the thickness of pericardium. There's no sacrosanct number of 4 or 5 or 10 that it really hooks up to. But then essentially when we look at, like at least today, we are looking at a multimodality approach. It's much more than just the clinical, the echocardiography and the cath, and let's see each of them in in its own individuality. The second question that I'm commonly asked is what is the pathophysiological basis? If you understand this is a very busy slide, but I'll just come down to the actual basics of it. The actual basics is just this. It's just exaggerated ventricular interdependence. Importantly, the word exaggerated again, because you have normal interventricular dependence, which actually gives us the normal, the change in volume to the respiration in a normal person as well. And the most important part is there is a dissociation between the intrathoracic pressures and the intrapericardial pressures because you have a shell in CP because there is no space there. So if you look at the inflow patterns, most commonly, this is actually structured more for the fellows, not really the front benchers. I've always been a backbencher, so it's for them. So when it's commonly believed that when we inspire in, CP, it's basically a shift of the inspired blood causing the shift of the septum to the left. It's not. It's not. It's basically because if you look at the hemodynamics, it's a difference in the pressures between your pulmonary vein and the wedge pressure. That is what falls when you inspire. It pulls the septum to the left rather than your inflow in the RV pushing the septum to the left side. It's basically, it's not possible because your RV pressure is 25 and you have your LV pressure is 120. So it's basically the change in the pressures that happens because of a dissociation of the intrathoracic and the intrapericardial pressures, because of which there is a fall in the gradient between the pulmonary vein and the LV EDP, because of which there is a shift of the septum to the left rather than a push from the right. That's something that's not commonly understood. Something that we are again, very morbidly struck with is the inflow variation. Again, you have a normal respiratory inflow variation as well. But then when we have an exaggerated, like inflow variation, which is more than 25% on the left side and more than 33.5 or say 40% on the right side, that is what sort of is a manifestation on the echo of the interdependence that we are talking about. If you see the AAC guidelines, it says that in the modern era, multimodality imaging is essential. Echocardiography is the initial test. And that's very important because, when we define these syndromes, it's very important to talk about echocardiography. It's a simple test. It doesn't require any amount of radiation. CMR and CT can usually be additive if there is any complexity, if you're not able to solve it with an echo alone. How can we diagnose CP versus RCM? I was actually talked about like this differentiation when we talk about, yes, clinical history is important. It's always important to understand that the phenotype of the patient is different. In India, though we talk about radiation, though we talk about, post-cardiac surgery, like post-bypass pericarditis, it's much more of tuberculosis even now in a lot of our part of the world. Hemodynamic is important, of course, as I said, echo and particularly Doppler, tissue Doppler, extremely important, which I'll come to, and now LVGLS, which is backed by the cath findings. This would be our approach to actually looking at it and using imaging only as ancillary. What are we essentially looking at? As I said, it's more of a mortal disease versus something that can be totally curable if it's possible, like as in terms of CP. And this should be our diagnostic algorithm. Now, if you go down the algorithm, it's very easy to understand this, that the first thing that you look about is there diastolic dysfunction, which is on the top right here. So you have a mitral inflow, which suggests that, and then you go down each pathway. And this is something which like as a recurring slide, I'm going to use throughout my talk. So if you see in terms of the first branch point, is there at all constriction or restriction? Yes, there should be. Okay, then it goes to the left side. Then we look at essentially the kind of tissue characteristics that we're looking at. Myocardial disease, RCMP is a myocardial disease. You will have slowing of velocities because you have something which is, like actually collecting there, amyloid or sarcoid or whatever. So you are going to have a slowing of disease. So your E prime is never going to be normal. Your E prime will not be normal. Tissue Doppler is one of the best ways to diagnose CP versus RCM, while your E prime will be preserved or even increased in CP, which I'll come to later. That's called as annulus paradoxus. So the point is, you will have to go with the second branch point where you have less than 6, 6 to 8. If you have any E prime velocity more than 8, that means your muscle is normal. That means it cannot be RCM, at least not very obviously. Then you may have to go for a second line investigation like a hepatic vein, etc. Now with VEXAS coming in, it's a lot more prevalent. So as I said, the first, it's actually a slide taken from JKO study, who's done a lot of like research on these topics, where the first branch point is septal motion. Are you going to be seeing this abnormal septal motion at all? Then comes, of course, the mitral inflow. Do you have a respiratory variation? Now, in this order, how sensitive and specific they are actually, which I'll come to later. But the point is, this all hooks upon to the interventricular dependence, exaggerated interventricular dependence. Then comes the hepatic vein Doppler, and then, of course, the septal velocities. Can we understand it through cath? A very, very brief touch upon on the cath. Cath essentially tells us that there is, again, the same thing. I'll again use the same words, exaggerated interventricular dependence, where there is a flow in the initial part of diastole, and then we have a square root sign. Why does that happen? Because the flow gets restricted. You have a shell around the heart. So you will have an increased atrial pressure. You will have a rapid and a limited filling in the initial part of diastole, which then plateaus off suddenly. So that is what is going to give you your square root sign. So if we have a simultaneous cath tracings, there is nothing to be done about interventricular, about intrathoracic, intracardial, intrapericardial pressure changes being affected in RCM. So they're going to be concordant. As much as the RV goes up, so much will the LV go up. As much as it comes down, so it is concordant. However, in CP, because there is a dissociation of pressures, it's going to be discordant. So you're going to have an increase in the RV pressure. If you have a simultaneous LV-RV tracing, you're going to have a decrease in the RV EDP, simultaneous increase in the LV volume. So because you have a dissociation between the intrathoracic and the intrapericardial, you will have a discordant change. Optimizing is important. This is something that we all use. We use low increased sweep speeds of about like 100, and we try to take the best plaques and the PSAX images, because a couple of things which are important, which can be seen, since I have a couple of slides which I can skip. I'm just bringing into it. So this is what is classically seen. So we have a respirophasic kind of variation, where due to inspiration, you can see that the septum is going onto one side, expiration, it goes back on the other side. And on the top right, the circle on the top is what is called as a septal shudder. All these are very, very classical findings of constrictive pericarditis, almost never seen in RCM. As I said, AAC uses this as a diagnostic criterion, and they even go to say that echo is more sensitive than even MRI. And the line which is mentioned in AC is consider constriction if there is a respirophasic septal motion abnormality. Respirophasic septal motion. So that's your first branch point in patients with heart failure and preserved EF. More than 25% of inflow variation, that happens because inflow variation is something that we'll have to calculate in terms of inspiration and expiration, get your respirometers well, and then see whether it happens. This is not something that happens commonly at all in RCM. As I said, posterior wall flattening, septal shudder, and a pericardial thickening. Again, do not go on to any number. There is no sacrosanct number. It's the hemodynamics which are much more important than a number. One hack that we have always used and we have been, like trained to use is something that we used to very commonly use in Sinai, because the patients are so big, like in US, you have to make them sit up. And when you do that, automatically the amount of your inflow variation will actually increase. It's something which you can use in the outpatient very commonly. It's the same patient which you have taken initially and then again taken with a sitting up position. If you are okay with the hepatic venous flow, you have to understand that you have three veins which enter into the IVC, and the classic flow that happens is an expiratory reversal in the diastolic flow. Which you have a systolic wave, you have an S wave, A wave, and a wave reversal. That becomes a lot more prominent in CP. So we have the M mode, which we take for. We have a dilated and a plethoric IVC. And on the right side, we see that the mitral valve, which has a reduced diastolic flow during expiration and a prominent AR. This is your AR, is your actual reversal, which I mentioned about here, like going up, right? So that's the one that is reversed and a lot more prominent when we have CP. This is something which is very, a real favorite of all our examiners in cardiology. As I was saying, Dr. Bagheera, JVP is the graveyard of cardiology. So this is annulus reverses and annulus paradoxes. Annulus reverses. Now, essentially what happens is when you have a normal heart, your lateral velocity, lateral E prime tissue velocity is a lot more than the medial. When there is a constriction, the shell holds on to the lateral wall. Your TDI parameters of your septal start to get larger than the lateral. Or rather, I should say the lateral become lesser than the septal parameter. So E prime of your lateral, I'll show it to you. E prime of the lateral and E prime of the medial, it's 12 and 8. So this is not something that we commonly see in a normal heart. In a normal heart, the lateral wall tissue Doppler E prime is a lot more than the medial wall. And again, there's something called as annulus paradoxes. Now, this is something which we all know from hemodynamics, E by E prime times 1-to-1 with your wedge pressure, generally. This is the one part where it will not. E prime is preserved. So your E by E prime will still be normal. In the face of an increased diastolic filling pressure, you still have a normal E by E prime. That's called as annulus paradoxes. And this is something which was described way back in 2001, even before reversals was described by JKO and his group. So this is what I was talking about. So E by E prime times 1-to-1, usually with the wedge pressure, but this is one area. CP is one place where you do not have E by E prime because the E prime remains high. Again, it is not a myocardial disease. So E prime will remain high. But in the face of an E by E prime, which is normal or relatively normal, you still have high filling pressures, or rather the other way around. If you have high filling pressures, you expect a low E prime. a low E by E prime, but here it remains preserved. So to recap, these are the four most diagnostic things that we look for in CP. We look for septal motion, as I told you. That's more or less the kind of algorithm that we follow. We look at 1, 2, 3, 4 in that sense, clockwise. The second thing is to look for a respirophasic change in the flow. Third is to look for tissue Doppler. Are you having a kind of a reversal pattern? That is, you have a lateral E prime. If it is low, that means you are having a abnormal pattern. You're having a restriction of that part, probably because of the tethering from the pericardium, thickened pericardium. And the last, of course, is your hepatic reversal. Again, to look for RCM, now coming on to this, the same kind of algorithm. Now we go on to the right side. Yes, there is you have a diastolic heart failure because E by A ratio does not amount to that. And in the face of this, you will start going on to the right side where there is much more of a tissue slowing. That means your E prime starts to come down. E prime comes down simply because it's a tissue Doppler velocity. Tissue Doppler means that if you have, like as I said, if you have sarcoid or amyloid or any kind of hemochromatosis, it will start to affect the velocity in the tissue. Classically, the four things on the top right. So you will still tend to have a DT which is very, very rapid. The E by A mitral, which is very, very high, it's not even 1.2, it's more than 2.5. And if you have if you have an isovolumetric relaxation time less than 50, it is 90% or more specific towards an RCM disease. As I said, E by E prime is more now. Your E prime has come down. So E by E prime starts to rise. Spectral tracking can be used. This is something that is being really spoken about. It's important because spectral tracking looks at the longitudinal strain, which is very much affected when you have a myocardial disease again, but it is preserved in CP. But the one thing here that's happening, anyone can tell me what this diagnosis is? You have actually the strain curves which are abnormal in the apical segment versus the basal segment, and you have an apical which is relatively preserved and a basal which is not. Apical to basal ratio more than 2.1. Anyone? Amyloid. Classically amyloid. So this is one of the diagnostic criteria for amyloid. I know I'll rush through, sir. As I said, tissue Doppler, I won't be repeating what is like already done, but if you have a tissue Doppler velocity of more than 8, it suggests CP in patients with normal EF and a heart failure. How accurate are these? Very, very accurate. If you see in terms of ventricular septal shift, this is what is the first branch point. Then you look at the E velocity. If you have 1, 3, and 5, that is if you just look at the shift and you look at the tissue Doppler velocities and the hepatic vein, you are more than 90% likely to hit the actual diagnosis of a sensitivity of 87% and a 91% specificity. Other modalities, I'm going to just touch upon them because CT, MR, they have their own place, yes. But then you really don't add much. You see the same things there, other than seeing other diseases along with this, of course, which might be important for the surgeon. But extensive pericardial calcification can be made out, and of course they can actually see in the better planning. I'll land up with just 4 cases which have foxed us in real life, because we're all clinicians. We need to see cases. 60-year-old male comes with the right upper abdominal discomfort and a dyspnea 2 years after CABG. Okay, you have a JVP examination which is suggesting that there is an elevation. You have an S3 which is prominent. The CT was showing a calcified pericardium. Sorry, sir. So these are 4 cases, one of which was TAVR done, but turned out to be an effusive constrictive pericarditis. Don't miss these in patients. Classic annulus reversus was seen. 52-year-old man waiting for heart transplant. The medial E prime 16, lateral 10, turned out to have actually CP. And the last case that came just last week, it was a 45-year-old man with dilated IVC. Having said everything that I did, a classic septal bounce. Having said everything that I did, the clincher was tissue Doppler, because all that he had was a large mass actually pulling, actually pushing his LV in, because the tissue Doppler did not lie. The lateral was clearly much more than the medial, which was not expected in a patient with a constrictive pericarditis. So summarizing, this is my diagnosis. If you have to diagnose, it's a clinical, hemodynamic, and an echo diagnosis. Other imaging is contributory only, ancillary, but diagnosing correctly is vital, because